Hi, this is Lindsay Sullivan back live at Bone and Joint Institute of Tennessee with our monthly Facebook Live series with our physicians. So today we have Dr. Geoff Watson, one of our foot and ankle specialists with us. So today we're going to be talking about Achilles ruptures. So you often hear about Achilles ruptures sometimes with athletes, sometimes with other populations. So we're going to kind of dig into that a little bit today. But before we get started, Dr. Watson, tell me a little bit about yourself, a little bit about your specialty.
Well, so my name is Geoff Watson. I'm a Tennessee native, grew up in East Tennessee, and so I went through training with orthopedics and actually did a 5-year residency in orthopedic surgery, and then did a 1-year fellowship in foot and ankle, and that was done at the Hospital for Special Surgery in Manhattan. Achilles ruptures are sort of a topic near and dear to my heart. My dad actually had an Achilles rupture as I first began residency, and was in Knoxville and actually had a missed Achilles. So the first physician he saw did not recognize that, thought it was just an ankle sprain. So it took him about 6 weeks to kind of get that figured out. And then, that sort of almost gave him about a 50% longer recovery in a bigger surgery to correct that later on. I can certainly see firsthand about how Achilles can keep you down, and it's important to diagnose them on the front end and help to get you back to doing the things you want to do on a quicker recovery time schedule.
So what exactly is an Achilles rupture? Can you tell us like where it is, and then how does it happen?
Yeah, so the anatomy of the back of the leg, from your knee down, you have two muscles that connect to the Achilles, both the gastroc, which has 2 parts, and then the soleus, which has 1 part attached to the Achilles tendon. The calf muscle that you sort of think about, that's the gastroc. And then those both attach to your heel bone or your calcaneus, and they help to function for push-off. So running, jumping, any high-level activity, generally the Achilles is required to do that motion.
Any particular population that it occurs in the most, or is it pretty much across the board?
So there's a few factors that contribute to that. The classic is a weekend warrior. Somebody like myself, mid 30s, 40s, who likes to work out only on the weekends, doesn't have time through the work week, and so he kind of gets these quick bursts at just short intervals over the weekend, and that's sort of the biggest risk factor for having a Achilles rupture. The other things that can go along with that, antibiotic use, like fluoroquinolones have a risk for that, and also steroid injections into the Achilles we strongly recommend against because they have a high risk of rupture.
So once somebody comes into your clinic, maybe with pain, or are there any ways that you can diagnose an Achilles rupture?
Sure, there's a few simple ways. One is called the Thompson test, which involves you laying on your belly with your feet usually hanging off the bed. You would squeeze the calf, and you can usually see the foot plantar flexor go down. If that doesn't happen, we're worried about an Achilles rupture and may consider getting an MRI potentially. The other way is simply, again, laying on your belly and then bending your knees up so that your feet are kind of hanging there. Generally, the foot will have what's called resting tension, so your foot will be pointing toward the sky. If you have an Achilles rupture, it'll generally droop down. That means the Achilles does not have tension to it. It's not connected anymore, and it's allowing that to happen. So those are the 2 most common ways that we can visualize that.
And is there anything that the patient or prospective patient can, if they think they have a rupture, like is there any common thing that they describe it as?
The story is very similar usually from patient to patient. It's usually, I thought someone kicked me in the back of the leg, and you turn around and nobody's there. It's basketball, tennis, all those. Almost when you're planning seems to be when it happens more often than actual like a quick burst activity. But that can generally happen. In fact, there's a pretty good video, if you remember Kevin Durant when he tore his Achilles. You can actually see the muscle kind of go in one of the slow motion videos, which is maybe a little bit much for some, but kind of fun for people like us.
I love it. So treatment of an Achilles rupture, is it always surgical or non-surgical? Could you kind of go into the 2 different options there?
Yeah, great. So traditionally we would always fix these, and traditionally there was also a pretty decent rate of infection, up to 5%. There's certainly been a lot of research, particularly in Europe and Canada, that have sort of suggested that non-surgical treatment is very effective if you're trying to get to an activity level of simply walking around. So that's usually a pretty effective way to get someone to heal, but it requires that patient to be seen within 48 to 72 hours. Certainly within 2 days is probably best. We have a lot of urgent care clinics that are open. There's a lot of accessibility to our clinic in general. So I do think it's important, if there's a suspicion, you should get it looked at quickly, because if that doesn't get caught early on, then your risk of re-rupture is much higher. We certainly don't want to do this again. When we do treat them surgically, it's generally to get somebody back to a higher level activity. That's a big factor in the way we consider this. So if you're someone who's very active, you run, jump, then that's when we're talking about surgery.
Okay. And what types of, could you go into a little bit of detail about surgery, like exactly what you would do?
Yeah, so the basics of it are, you're trying to reset the tension. So basically, the tendon is torn and the calf muscle still works, so it pulls the tendons apart. So what we want to do is put those tendons back together. So generally speaking, it's putting suture in both ends of the tendon to basically tie them back together at the same tension. So restoring the tension is the main goal of surgery. We used to do that through a big open incision, and there are some occasional times where you have to do that. But now we've had a newer innovation with a percutaneous or small incision. It ends up being about 1 inch long. But we have a device we can track underneath the skin and throw suture through the tendon and then pull that suture back out and kind of do that above and below. And that allows us to reset the tension through a smaller incision and decrease our chance of wound healing problems.
Awesome. So after Achilles, either surgery or non-surgical options, is physical therapy key in that, or is it something where the body just needs to heal?
It's probably just as important as surgery, and that's coming from a surgeon.
Okay.
So I think that therapy is huge because really it's quite surprising how quickly you lose that muscle mass. So even just a few weeks in a boot, you can really lose some of your muscle mass, and gaining that back can sometimes take 6 to 9 months, and that's usually a big portion of recovery, is gaining that muscle mass back. So therapy is, whether doing it on your own or self-directed or with care of a physical therapist, which is usually what we do on the beginning side for sure, it is very helpful and very important to getting you back to doing the things you want to do.
Awesome. And as far as prevention, are there any ways to prevent an Achilles rupture?
Yeah, we always think of that as sort of like a little daily hygiene, just like you brush your teeth twice a day, maybe, hopefully. You could also stretch your Achilles at the same time. A lot of people will have a stool in their bathroom, and kind of while they're brushing their teeth, they can kind of hang their Achilles off the edge and stretch it, and that's pretty effective. And also just sort of maintaining whatever quality of exercise you like to do throughout the week can also be helpful.
Awesome. Well, Dr. Watson, one question that we always ask all of our physicians that come on the Facebook Live is, describe the comprehensiveness that Bone and Joint offers patients. So you've mentioned urgent care, you've mentioned surgery, you've mentioned physical therapy, and we have multiple locations for all of those around Williamson County. But in your own words, how does this help the patient experience?
Yeah. I think it just keeps it all consolidated so that the open lines of communication between all our different parts are very easy. It's simply, we've all got each other's phone numbers. We just pick them up and call the therapist or the whoever's running the urgent care, one of the physician assistants, and I think that's what gives us an advantage over some of the other groups.
Awesome. Well, Dr. Watson, again, thank you for your time today. We really appreciate it. If you have any questions for Dr. Watson or would like to schedule an appointment, you can visit our website at boneandjointtn.org or give us a call at 615-791-2630. Dr. Watson, thank you again for your time.
Thank you, Lindsay.
Thank you.
Thank you.